welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hi everyone, I'm Rachel Eccles. I am a PGY2 at WakeMed Health and Hospitals here in Raleigh, North Carolina. Today we're going to be talking about a meta-analysis and systematic review of correction rates and clinical outcomes in hospital patients with severe hyponatremia. I do not have anything to disclose today, and neither does my mentor for the day. And for the objectives, we're going to review pertinent background literature of hyponatremia, discuss current serum sodium correction rates, and evaluate some primary literature regarding the correction rates and clinical outcomes in patients with severe hyponatremia. So for a little bit of background, hyponatremia, defined as serum sodium less than 135, is a primarily disorder of water balance with a relative excess of body of water when compared to total body sodium and potassium content. It's usually associated with vasopressin, which helps maintain the fluid balance, occurring in up to 30% of hospitalized patients. So it's very common. A lot of us see it on a regular basis. So this common disorder remains incompletely understood in many areas because of its association with severe underlying disease states. And there are multiple etiologies and differing pathophysiological mechanisms with difference in symptoms and clinical outcomes based on the acuteness or chronicity of hyponatremia. For example, acute hyponatremia patients can present with seizures, delirium, or altered mental status, whereas with chronic hyponatremia, so these patients with serum sodiums less than 135 for more than 48 hours is associated with nausea and vomiting, fatigue, headache, but also may include some neurological dysfunction and seizures with very low serum sodium levels. Due to those reasons, optimal treatment strategies have not been well defined. Acute hyponatremia is associated with a significant morbidity and mortality that we would like to avoid. Acute hyponatremia should be distinguished from chronic hyponatremia when able, since rapid overcorrection can result in osmotic demyelination syndrome, which we will discuss on the next slide. So with osmotic demyelination syndrome, one of the major risk factors for ODS includes a rapid shift of sodium levels leading to breakdown of the myelin sheath. And as the myelin sheath breaks down, the demyelination of the nerve fibers occur, resulting in dysarthria, dysphagia, and quadriparesis. Historically, there's a low risk of ODS with up to 0.8% of patients with a rapid sodium correction experiencing ODS. And newer data has actually shown that while rapid correction of sodium was common in analysis, the rate of ODS was rare, reported in 0.05% of patients. So osmotic demyelination syndrome, a couple of clinical features to be aware of. So some slurred speech, joint pain, difficulty swallowing, and then altered mental status. You can also see muscle weakness with quadriparesis and coma and death. The good news is that there are some known risk factors for ODS that can help identify the appropriate sodium correction rate. Those patients that we would think of with a high risk of ODS have severe sodium less than 105 millimoles per liter or milliequivalents per liter. Patients with hypokalemia, alcoholism, malnutrition, or advanced liver disease. Keep these risk factors in mind as we go through the presentation, and we'll refer to them as we talk about differing sodium correction rates. Due to the risk of ODS, current guidelines recommendations include limits on the rapid increase of serum sodium levels. The U.S. guidelines presented in 2013 report recommend a correction of 10 to 12 milliequivalents per liter in any 24-hour period, and limiting that correction to 8 milliequivalents per liter per 24 hours in patients at a high risk of ODS. So think again about our patients with malnutrition, chronic alcoholism, or severe hyponatremia. There's also an overarching max of 18 milliequivalents in any 48-hour period that we don't want to exceed. The European guidelines, which came out a year later in 2014, offer a little bit more of a conservative approach. They recommend a max rate of 10 milliequivalents within the first hour, and then the first 24 hours, and that drops to 8 milliequivalents every 24 hours after that until the serum sodium is above 130. The European guidelines also recommend re-lowering of the serum sodium if you exceed the recommended rates. However, since the release of these guidelines, now it's been 10 years since these have been released, there have been several studies published regarding the rate of sodium correction and the risk of ODS that recommends potential differing opinions compared to these guidelines. So with that, we will get into our study for the day. With our study of focus, we'll be reviewing a systematic review and meta-analysis of the pertinent studies published 10 years following the 2013 hyponatremia guidelines. The primary objective was to evaluate the association of sodium correction rates with mortality among hospitalized patients with severe hyponatremia. As with all systematic reviews, a comprehensive literature search of multiple databases was completed, including studies published after the publication of the updated guidelines, so from January 2013 through the end of 2023. Each selected study was assessed by a pair of review authors, as well as the references searched for additional inclusion into the analysis. Risk of bias was assessed using the Robbins 1 tool, which evaluates the risk of bias in results of non-randomized studies of the interventions that compare the health effects of 2 or more interventions. Studies were included if they compared rapid versus slow sodium correction in adult patients with either severe hyponatremia, which was defined as a serum sodium less than 120, or severe symptomatic hyponatremia with a sodium of less than 125, but with the symptoms of cardiorespiratory distress, seizures, GCS less than or equal to 8, or a decreased level of consciousness. Trials were excluded if they were participating in a preclinical phase, studies outside of the inclusion timeframe from 2013 to 2023, and then if severe hyponatremia was not included. Studies were also excluded if the rate of sodium correction was not reported. The primary outcomes of this trial was to look at in-hospital and 30-day mortality, and secondary outcomes included hospital and ICU length of stay, as well as the rate of ODS. It is important to note here that a formal definition of ODS was not used in the meta-analysis. Rather, they used reported ODS events depending on each included study definition. There were a variety of statistical analyses used for the systematic review, with meta-analysis being completed for each comparison and utilized calculated risk ratio or odds ratio for mortality and ODS. Mean differences were utilized for the length of stay, and when able, data was adjusted for the age, sex, race, admission sodium, alcohol use, and the Charlson Comorbidity Index. This meta-analysis also considered a heterogeneity, or I-squared, as greater than 60% substantial. These are the definitions of sodium correction that they used in this meta-analysis. There is a little bit of overlap due to differing definitions in the included studies. So very rapid was defined as greater than 12 milliequivalents per 24 hours. Rapid was 8 to 10 milliequivalents per 24 hours, and then slow was less than 8 or 6 to 10 milliequivalents, and then slow was less than 4 to 6 milliequivalents. The main focus of the trial is comparing rapid versus slow and very slow in terms of outcomes, and we will discuss that when we get to our outcomes. In total, over 5,000 records were screened for potential inclusion, with the majority being excluded due to study design published prior to the January 2013 cutoff. They were conducted in pediatric patients rather than adults and had no rapid or slow correction. There were 16 included studies with 14 retrospective cohort studies, 1 prospective cohort study, and then 1 randomized clinical trial that ended up being analyzed as a prospective cohort study since it did not randomize sodium correction rates. There were varying studies included in each outcome of this analysis, depending on the endpoints reported in each individual trial. Reported baseline characteristics included a mean age, with the most studies with a mean age greater than 60 years old, and then we had a predominantly female population with 56% of patients being female. This graph reports the risk of bias, with red indicating a high risk of bias. There was a high risk of bias due to confounding in all of the trials, and then 2 additional studies had a serious risk of bias due to deviations from intended interventions, and 1 in the measurement of outcomes. Bias in the selection of participants, classification of interventions, missing data, and the selection of reported results was assessed as low for each study. For outcomes, I had mentioned most focused on rapid versus slow or rapid versus very slow. It is important to point out here with the asterisk underneath the table is that for the analysis purpose, rapid was included with a correction of sodium 8 to 12 milliequivalents per the first 24 hours. Slow correction was less than 8 or 6 to 10, so still a little bit of overlap there. And then very slow correction is less than 4 to 6 milliequivalents per 24 hours. So it was a little bit more defined than the initial groups, but it was a tad confusing that they altered from their initial definitions. It was found that there was a lower adjusted in-hospital mortality from over 6,000 patients in 6 studies with the rapid compared to slow versus very slow correction. The adjusted in-hospital mortality was again adjusted for age, sex, race, admission sodium, alcohol use, and Charlson Comorbidity Index, and found an odds ratio of 0.59 and a number needed to treat of 25 patients for rapid correction compared to slow or very slow correction. The study found a probable dose response effect when comparing rapid versus slow sodium correction, as well as rapid versus very slow correction. There was also a significant reduction in 30-day mortality as well, with a relative risk of 0.55 in the rapid versus slow group and a number needed to treat of 17%. Overall, you can see from this table, there was a larger difference in outcomes when comparing rapid versus very slow in these patient populations. I included this slide here to show the individual trials and their outcomes individually for the adjusted in-hospital mortality outcome, with most significantly favoring a faster correction on their own. The heterogeneity is also shown there as the I-squared, and both adjusted in-hospital mortality was less than 60%, was the study cutoff for significant heterogeneity. Also to note, the risk of bias is shown on the right-hand side of the screen. Green is good, has a low risk of bias, and that was most of the included studies, which is great. For the secondary outcomes, there was reduced hospital length of stay found in rapid correction versus slow and very slow, with up to 3-day shorter ICU length of stay in the rapid correction versus the very slow. And then with up to a 3-day shorter ICU length of stay in the rapid correction versus very slow. ICU length of stay showed reduced ICU length of stay, but the heterogeneity was greater than 60%, so it was not statistically significant. ODS was an important safety outcome of this meta-analysis and overall did not show a difference when comparing the groups for ODS with rapid versus slow or very slow. The rates for each correction category was less than 1%, with 0.3% in the very rapid group, 0.5% in the rapid group, and then 0.2% in the slow correction. So based off these results, the authors concluded that a slow correction of sodium was associated with an increased risk of mortality and a longer hospital length of stay when compared to rapid correction. They found that this was further supported by dose response effects with no statistically significant higher risk of ODS, suggesting a very favorable net benefit with rapid correction, which again they defined as greater than or equal to 8 to 10 milliequivalents per 24 hours. Overall, this meta-analysis does adhere to the PRISMA, or the Preferred Reporting Items for Systematic Reviews and Meta-Analysis Reporting Guidelines, which is recommended for systematic reviews. It also meets a crucial need of literature, since the last updated guidelines are now over 10 years old. However, this trial was limited that it has a high overall risk of bias for the included studies. And as with all meta-analyses, it was limited by the heterogeneity of the inclusion and exclusion criteria, as well as different definitions of sodium correction rates and then osmotic demyelination syndrome between the studies. Another limitation is that it was unable to classify patients as acute or chronic hyponatremia, which could affect the rates of ODS. But in real practice, it can be hard to differentiate acute versus chronic hyponatremia. There was also not a baseline serum sodium mentioned, although we know that at least this patient population was less than 125 at the start of the trials. And then, as I pointed out, the sodium correction groups were analyzed with a higher goal that was not reported as the initial sodium correction groups. Along with that, the average sodium correction per group was not reported. So not sure if, like for the rapid correction group, for example, if they favored more on the lower end of the 8 milliequivalents per 24 hours or on the higher end of 12 milliequivalents per 24 hours. And lastly, the rates of ODS may have been underreported due to the required confirmatory imaging findings that are required for an official diagnosis. So based off this meta-analysis and some of the background data we discussed earlier, I believe we could target a rapid sodium correction with 8 to 12 milliequivalents per 24 hours in patients with low risk of ODS. There is not a set sodium correction rate that is appropriate for every patient, so it's important to keep individual patient characteristics in mind, such as considering the chronicity of hyponatremia or the baseline serum sodium that they're presenting with. It is important to ask if we are hurting patients by being too cautious with a slower correction rate, since in this study they were associated with a higher mortality and a longer hospital length of stay. But overall, ideally we can get some larger prospective studies prior to widespread implementation of a higher rate. It also would have been nice they included a little bit more of the very rapid correction in terms of the analysis. They just reported the rates of ODS separately, and we did not see the comparison of very rapid versus rapid or very rapid versus slow. And with that, that is all I have today, and I'd be happy to take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.